Thank you, David, for that kind introduction, and Jens for the wonderful lead-in in terms of what we're going to discuss today. Because this is a fine body that we're looking at both the dense physical aspects and the subtle psychological and their interaction and overlap. And that's where the body comes in, and that's where this work with the unconscious comes in, because this is the core of our work as clinicians. Dr. Waddell, I got to know him when I first came out here in the late 80s. This was a time Alf Nachemson and the Boeing study was going on, and we were looking at factors and return to work issues in terms of low back pain, where we found that patients that had a poor employee evaluation were less likely to go back to work than those who had good relationships. So that's not a dense anatomic problem, but that is more of a relational and subtle and consciousness relation. So it's interesting that synchronistically, that in 1980, Dr. Waddell published his classical award-winning paper, Non-Organic Physical Signs in Low Back Pain. That's 35 years ago. It's the same year I started medical school, and at that time, still 50% of the department chairs of the Department of Psychiatry were analysts, primarily classical Freudian analysts. And additionally, Arthur Kleinman, who was at the University of Washington, later retired as chair of anthropology at Harvard, who's both a psychiatrist and an anthropologist, defined and published on the concept of the explanatory model. How do we explain these things? And that's an interpretive framework denoting the beliefs, values, perceptions, and expected course of action of clinical encounter or illness. So what meaning do we give that? Do we consider this a simple anatomic problem that should just get better and you just get it fixed? Is this a part of a family legacy? Everybody in my family has back pain. Or is this some sort of punishment for wrongdoing? How do we define this? So it's important to see things in terms of what I'm trying to discuss with us this morning, that this is part of our heritage. Dr. Waddell is an orthopedic surgeon who is a researcher in illness, disability, and response to examination techniques. He's seen the patients we have. Historically, we'll look at most of the people, because there was not a psychoanalytic movement, and most of these people were seeing the exact same patients we were seeing in clinic as we do today. So we're going to put this in an overall broad context. We're going to define what the unconscious is, which is no small feat. And lastly, we're going to look at the body as shadow. I'm not going to spend time going over the specifics of Dr. Waddell's signs, but what he found scientifically in his research, that if one presented with 3 of these 5 findings that are said to be non-organic, this suggested in his original paper that there were unconscious factors that were dominating or at least should be looked at. Unfortunately, and I think those of us who train residents, I train residents and medical students, they said, well, these are signs that show that the patient's malingering and or a faker. Well, when Dr. Waddell was on the podium with me in 1991, he just went nuts. And I wish I could, I tried to get a Scottish accent. I cannot do it. This is not true at all. This is a misuse of these signs, these suggesting that there are other things going on. And he said, at best, what we're looking at is a yellow flag. We should look deeper. What I would have to say is, working with my colleagues when I was in training at the Jung Institute here in town, is that when a patient presents to the psychotherapist, the key thing is to really understand is it's never about what it's about. That is to say, oh, I'm not getting along with my coworkers. There's always something else why they present in the clinic, and so why does this patient now come into your clinic presenting with spinal pain? So there's always other factors. These factors are ever present, It's just how dominant are they. So these signs for the clinicians to purse out and find out how significant they are, it's very important to use. Dr. Waddell is a man after my own heart. He has similar interests, and also it's important to look at, I didn't know this as I was looking up for my presentation, he's also serves as professor of the British School of Osteopathy. And for me, I have equal interest in osteopathy as an MD, as does Dr. Waddell. So it's really wonderful. So here we have two luminaries. To our left is Sigmund Freud, who was born in 1856, and to the right is Carl Gustav Jung, who was born in 1875. These are the two figures that brought to our modern understanding of the 20th and 21st century understandings of the unconscious. It's also important to recognize that they were not the first to recognize the unconscious. Here I have a list of notables, and really in modern times, at the bottom is Anton Franz Mesmer, who was born in 1734, more than 120 years before Freud. He is probably the one who is responsible for this. The classical tome on the discovery of the conscious, written by Ellenberger in 1970, has a wonderful delineation of that. So Freud was a neurologist who was originally a research scientist doing neuroanatomic research prior to needing to go into clinical practice to make money. And he would have preferred to stay in the scientific realm. And he is a neurologist and a neuroanatomic researcher. Jung is the only person who worked with psychiatric problems, and he was in those days known as an alienist. Adler was an ophthalmologist turned GP turned psychoanalyst. So we have Freud, who brought us ego, id, superego. Jung in terms of psychological types, the terms introvert, extroversion, and then the inferiority complex is from Adler, who was a GP turned analyst, former ophthalmologist. So these people were seeing everyday people with blindness, with all these sorts of mixed presentations that were not clearly only dense physical problems. Maurice Nicole was working with Jung, published his second book in Dream Psychology in 1920 before he met Ospinski and later Gurdjieff, and looked at things from a three-centered knowing point of view, which I'll bring into when we're talking about the shadow in terms of the domain of the unconscious. And Bion was important in terms of bringing and looking at aspects from severe post-traumatic stress disorder. So we see in our patient population, especially in chronic pain, more than 50% of these patients that we're seeing have severe psychological problems. And so if we're only focusing on the dense scan, and I know we're not here doing that, everybody here is looking at this as a total package. I also now put down Aaron Beck, who was David Burns's instructor. Dr. Burns, Dave and I took some training from him, and Aaron Beck was a Freudian psychoanalyst who found that the long-standing psychoanalytic treatment was not working very well. So he worked to develop what's now come to known as cognitive behavioral therapy, which is the dominant modality, but we need not lose track of the subtle motions of the unconscious or the unseen factors. Because if we neglect the dense anatomic or neglect the subtle, we need to bring them both together, and I think that's where this group is going. So what is the unconscious? What would be a good elevator talk to talk about what is the unconscious? Well, the unconscious, simply defined, is best known as anything that's directly outside of our present moment awareness. Take a breath and think of your feet. How many of us here were thinking of our feet a moment ago? Nobody. but it was always there. Our sensation of our feet, our knowledge of our feet was always there, but it was outside of our present moment awareness. Additionally, it's important to know that the unconscious is vast and unknowable, and it's also a location, both personal and objective. So we look at the unconscious, it is a big, never-ending and unknowable source of both healing and consternation for us as clinicians. So from a three-centered perspective, the domains of the unconscious are visual, emotional, and somatic. What we can't see, sometimes you'll not have it, you'll miss the exit as you go. You're in some sort of state, trance state, you'll miss an exit, you'll bump into somebody, or you can't see what are you talking about? What did I do? You just can't see your own behavior, and that's outside of your awareness. Emotionally, you can look at the unconscious from a patient not being aware of their own emotional states. So you as a clinician will see somebody tense, get red, and you just told them they don't need surgery, and they're angry, and you say, "You're angry," and they say, "I'm not angry." That's denial. "You're angry." That's projection. So we can be emotionally unaware and unconscious. And lastly, more dear to Dave and I, as the somatic unconscious, that is to say, we don't really know where our golf swing is from a skeletal perspective. Am I coming over the top? How come I hit behind the ball? You just don't have a good sense of our own body awareness. And then there's the visceral unconscious. We don't really pay attention. We don't have to put our minds to digesting our food or being sure that our blood pressure. So we have a somatic component of the unconscious. So we have a vast, unknowable unconscious that has been progressively neglected as we've gotten more and more on seeing the objective behaviors. But again, we have to look at the motivations and the things that are underneath. And when we talk about the unconscious, we can think about things in terms of being underneath what Freud called was the repression barrier. The unconscious is important because all healing and all learning occur at unconscious levels. What I mean by that is one can become from consciously incompetent. When you first learned how to drive a car, you were like, where's the gear shift, the brake pedal, gas pedal? If you try to learn to drive it, and you get all tied up. But as you integrate that over the course of time, it just becomes unconscious. You put the key in, car in, put your left foot on the clutch, and you start pulling back. So you become unconsciously competent. So all learning is unconscious, and you need to be aware, but it's at those transitional points. Dave taught a course called Awake at the Wound, where he found that most errors occurred at transitional points where you're changing from one mode to the other. So that's important to have a strong respect for the unconscious at all times. In terms of, again, viscerally, wound healing, you don't think about how many white blood cells you might need or how that wound will heal. It heals unconsciously. So all learning, all healing occur unconsciously. So the location of the unconscious, there's a personal unconscious and three domains: the repressed, the infantile, and personal experience. Repression can be looked at from the point of view of there's a flow of consciousness that is going on, and what happens over time is that there are areas that you just don't want to look at. So it's like a river, and you press down a log, and depending on how turbulent you are, and this is where mindfulness and stability come in terms of our working with our patients, is you're holding that log underneath the water, and sometimes it can erupt into your consciousness, and you get, somebody, in the vernacular we say somebody pushes your buttons. So that which was repressed comes forward. The infantile really is just our basic dependency needs. We need to pay attention to our own dependency needs, and then there's our own personal experience. And that is to say, remembering that fine location, or remembering when you first met your beloved, these kinds of things. And your memories are colored by your own typology. I'm a mental person, so I remember dates, facts, those kinds of things. You meet other people, and they kind of like, oh, I remember. My wife remembers things by what she had for dinner that day. It's, don't you remember we had this great steak? So that's the personal unconscious. There is also the objective unconscious. So there are patterns that have come up over the course of time. And these are fundamental patterns that recur over time that keep the species going, that we share in common. Everybody's had a mother. Everybody has a relationship, parent-child relationship. These patterns just occur unconsciously. So what happens when you're interacting with somebody without awareness, you get into a bonding pattern. So we'll look at the adoring parent and the dutiful child. So, surgeon has a good fellow, they've done good work, but all of a sudden there was an error, and it goes, and the fellow says, no, I didn't make an error. So you go from adoring parent and compliant child to rebellious child to critical parent. These dynamics are always there underneath the surface, and without some stability, they can rule your life, and this is where people get into trouble. So in terms of the models of the unconscious, Freud had the simplest model that he described in 1923, which was the I, the ego, the over-I or superego, and the instinctual energies of the id. And this, the I mediated the wishes, desires, and drives of the id versus the shoulds of society and the parental. And this is a model that is not fully accurate, but it's a good taking off place. Jung looked at the unconscious from a more broad perspective, objective part of the objective psyche. And we can see that when one looks at only the small focus, if we look at the ego as a content of the psyche, you get very self-focused, and you have your own personal history, you have the collective history, and then things become knowable. So as one becomes progressively more aware, it's like a circle. So the circumference of the circle gets larger. So the more you know, the more unconscious becomes available to you, but you'll never know everything because the unconscious is vast, unknowable, and needs to be respected. I put this slide in here for a discussion to let you know that the classical Freudian people say, here's the integrated analyst or clinician, and you are the patient, and I know what needs to be done. But Jung said, no, the patient interacts with us. And so we have a relationship between the consciousness of the clinician and the patient, and the unconscious of the clinician and the patient, and our own relationship, and they cross-fertilize. I had a case with Rod where he sent me the woman who was in her 50s, 14 years out in a recurrence of breast cancer. She had an 80-year-old father who was a retired physician who was needing help, and a couple of daughters in college. She had corpectomy and instrumentation, and she was in a lot of pain, but she is yet very positive. In fact, so unusual. I said to her, I said, you're really different. Can you tell me about what's going on? She's coming to me because she has pain, and she said, Doctor, do you know how many good organ systems I have? So I don't know if I was there for her or if she was there for me. She impacted me. I've shared this with my other patients. And so our relationships in terms of the clinician-patient relationship is essential. The language of the unconscious, really, the language doesn't, it's not a linear. It speaks in symbols, in poetry, and fantasies. It's also quite literal because there's no there. So my somatic unconscious, unfortunately, gets a hold of me is like if I'm focusing, I said, there's some water, don't hit the ball there. Pretty soon you're in the water. The unconscious needs to be respected, and when you work with mind training, it's key. Oh, I'm missing my picture. The shadow. The shadow is important. Not to make a big deal about the shadow, Jung said, it says everything that's unconscious is in shadow. It's often undeveloped, unadapted, undifferentiated, and disowned. So it just so happens my last patient, I couldn't have planned this better. My last patient, 4 p.m., was a new patient, was a 16-year-old young girl, comes in with her mother, and she comes in because she has back pain because she's been falling because she's been having fainting spells since the last 18 months. So the mom, first thing she says about her daughter is, my daughter is a superstar. But I know she holds her head back, she faints, and I know you do manipulation. She's benefited from manipulation in the past. I'd like you to see her. And it goes on and on and on. And this little Irish girl's got red hair, and she's hearing about being a superstar, and she gets a big blush across her chest. And organically, the history unfolds, and I finally, it comes to, I said, this is somebody who's holding the superstar space in the family system. And it turns out when I said, she's 16, but she's got a 27-year-old brother later on. So tell me about your half-brother who's in California. Oh. Well, the half-brother is addicted to Percocet, has mental illness, and is estranged from the family. This woman, this little girl, is holding the power. Then the wife, the mom says, oh, yeah, we tried to get her into therapy. I said, you tried, and all of a sudden this was a physical problem. She said, so about 50 minutes into the appointment, she says, yeah, I tried to get her into therapy. Why? Well, we're such a dysfunctional family. I wanted her to go to therapy. At the end of this, I was able to manipulate her, give her some physical relief, and I set her up with a psychotherapist. But again, it's never about what it's about, fainting spells and back pain, when it's really about the 16-year-old holding the place of the superstar to take the place and heal the family. And I gave the girl permission. I said, you do not have to heal this family, but we do have to have you work with some writing and journaling and finding out what's important to you. I'm going to skip this so I can take some questions, but we're all on a journey, as we see from this quote from Lewis Carroll. So I'd like to take some questions now.